Dr. Hewitt, thank you so much to accept to participate in this project. So we heard you talk about how and why establishing a risk profile for athletes could be extremely interesting regarding ACL injuries. So I will start with the first question. How would you define a risk profile for ACL injury?
Well, any risk profile, you're going to develop a series of algorithms that you're going to validate over time to determine a risk profile for an athlete. So we actually started this work back in the mid 90s, and I would suggest for an overall scoping paper of this to look at our 2019 paper in Clinical Journal of Sports Medicine. Myself, Wendy Hurd, and Kate Webster wrote an exhaustive paper on this. So the short term for this paper we call our 5 facts max hypothesis. So what that means is, the idea is if you have a predictive variable to put somebody in a risk stratification profile, you're going to want a correlation better than, say, R is equal to 0.4, and that is going to account then for a minimum of about 20% of the variation of your overall model. Well, if you want to each factor incorporated into your model to account for at least 20% of the variation, that means you need no more than 5 factors. So this is what we proposed in 2019 and what we've been trying to put together ever since. I think it's important to state too that these are not prediction models per se. We use the term prediction because that's what a statistician will say that that's how you use, or what logistic regression analysis is doing. Now, I would suggest a paper I wrote in JOSPT on a commentary in 2017 regarding the risk prediction versus looking at risk stratification, which is actually what we're attempting to do. So again, not prediction in the sense that we're going to try to predict a specific athlete is going to have a specific injury, but risk profiling an individual to tailor and target training programs and interventions to that individual.
Okay, great. And do you think there is a best time to evaluate this risk profile in preseason, mid-season, or end of the season? And should we keep following it 1, 2, 3 times during the season?
Yes, all of the above. And I think first preseason for sure. So you want to develop the profile well before the season, as soon as the athlete reports, so that you can start developing the profile and developing an intervention before regular league play starts. So you want that early preseason measurement to start your risk profile, but then you also want to inform your risk profile by building longitudinal data sets. So I would say during a season, you want 3 recordings at least. We actually, with many of our athletes, we try to do it every 30 days, but at minimum, you want at least 3 points to validate your model, because 3 points are going to tell you whether you actually have an actual linear relationship over time. So I would say at minimum preseason, mid-season, and just postseason. That's going to give you a lot of good longitudinal information to build good models for that athlete.
Okay, great. And I have a question. Taking into account all this information, does establishing a risk profile is easy to implement in practice concretely?
Well, that is challenging, and we cover that concept in the 5 facts max hypothesis paper in 2019, which is what we've done is develop these profiles biomechanically. Usually we're using expensive equipment, but then in parallel, what we've done is try to do very clinically based measurements that any clinician could do in their physical therapy environment or their clinical office environment. So the good thing is a lot of this parallel work has already been done so that people can actually take what we've done over the last 20 years in the laboratory and apply it directly in their clinic.
Okay, great. Which are the main concepts we need to focus on to establish the risk profile for an ACL injury? So the motor control, movement quality, muscular, neuromuscular imbalance.
Yeah, so again, we're going to try to focus in 5 areas, and we developed a generalized model. So first thing you want to look at is anthropometrics. So for example, in our primary ACL risk prediction stratification profile, what we showed was body mass is always a predictor. It's so the bigger you are, the greater the mass. It's just simple physics. The higher the forces on your body, the more risk you have. This is why, for example, in NFL players have such high risk profile. They're such large individuals, just like NBA players, and so you look at anthropometrics. So height, weight, limb length, those kind of measures should be looked at, and they are often predictors. A second measure that always comes out that gives a variable in the range of 20% is strength. So some measure, if you're looking at a lower extremity injury, some measure of lower extremity strength. I really like a counter movement vertical jump. It's a very reproducible measure of whole body power. So strength, power. The third variable you want to look at is some aspect of movement biomechanics. So what we know for the ACL is that valgus, that dynamic valgus motion of the hip and the knee, the caving in toward the midline, is a good risk stratification variable. So we incorporate that into our measures. And then some measure of proprioception, kinesthesia, balance should be incorporated. And something like an unstable device or platform that can measure sway can give us a predictor in the range of R of 0.4 or better. And then finally, we have to take the brain into account. So we usually build into our models some measures of psychological readiness, fear, preparedness. And for the ACL, for example, we use the ACL RSI, the Return to Sport Index. So what we do is measure across that set of variables in each category, pull out the best risk stratifier out of those variables, and then put that together in an algorithm. And there you get a risk prediction stratification profile, hopefully with a sensitivity of at least 0.75 and a specificity of at least 0.75. And that can start allowing you to stratify into risk profiles and then build interventions that are actually going to increase the resiliency of that athlete and reduce their risk of injury.
Okay. Very interesting. And for example, you talk about the counter movement jump, which reproduces a lot the condition of games. Concerning screening exercises of the evaluation of the risk profile, which would be the ones that are the most relevant to suspect an athlete at risk?
Yeah, so I do like the counter movement jump. I like the drop vertical jump. So the drop vertical jump is really nice because there's a lot of data on it. We've been using that as a risk profiling tool for more than 20 years. There's a lot of data in the literature. So basically, the reason we use that is because there's a couple aspects to it. It gives you an overall measure of body power, so you can look at the jump height, but it also gives you a measure of coordination. For example, if you do your counter movement jump and look at your max vertical height, so we've always done both. So we take a counter movement jump, we measure the max vertical height, and then we set a target up at that max vertical height, and we do a drop vertical jump test. So there, it's a 31 centimeter box or 1 foot box in English measure, and they drop off the box, and then they go and try to hit that target. Usually we use a basketball, for example, that we set at that, but whatever target you want to utilize, but it should be set at their maximum vertical height from their counter movement jump. Now, if an athlete is well coordinated, they actually can get higher. They can get a boost from that drop vertical jump, from that plyometric effect of dropping off the box. But actually, if they don't have good whole body power and coordination, their vertical jump actually drops. So it gives you a measure of coordination, whole body power, but also you can get the kinematics, and if you have a 3D motion lab, the kinetics, the forces and torques across their joints of interest to develop your risk profile.
Okay, great. So we talk about strength and power, but also does monitoring the volume of training through physiological variables could be interesting to be included in the risk profile of the athlete? And yes, which would be the more relevant variables to monitor in athlete?
Yeah, so I think the most relevant variables in that area are total volume of work.
Yep.
And I think, putting that in, what you have to do is validate it, though. You need to look and see how it does correlate to your risk stratification. It's very dependent on the sport and what injury that you're looking at. So for example, in the ACL injury, people have said forever that fatigue is a risk factor for ACL injuries. What we've demonstrated is that's really not accurate. And Francesco Della Via just put out a paper that showed the same thing. So maybe for ACL injury, that's not a primary variable that you need to look at, but other injuries that are more related to overuse, those are certainly relevant, and you can build that into your model.
Okay, very interesting. Let me ask you another question. Is this interesting to evaluate the risk profile of the athlete at the end of rehabilitation or during the phases of return to play after an ACL rupture?
Yes, absolutely. So again, you're going to want longitudinal data, and I would suggest at least 3 data points. So as early in the post-surgical process as you're willing to test. So when we worked with our surgeons and physical therapists in the past, we need to find a point at which they're comfortable with the athlete being tested, say with a counter movement jump and a drop vertical jump. But as soon as the medical team is comfortable doing those 2 tasks and your balance and strength tasks, you get that data, and then midway through the process of rehabilitation, so say at the end of your traditional physical therapy and at the beginning of your return to sport training, and then at the end when you're getting ready to release them back to sport. So again, 3 data points to get a nice linear curve. And I think there's there was a paper recently that Joe Hart put out that said you're not going to see a change in that until about 2 months. So if you want to use, time aspects as earlier into the rehab process as the medical team is willing to do it, about 2 months into it, and then about 2 months after that. So, and again, we don't really use time so much because that's so variable between people. That's just a sort of generalized measure concept there. But you want to get 3 points somewhere at the beginning of the rehabilitation process, around the middle, and at the very end before you release them back to the field, to make sure that their improvements are there, and also so that there's minimal risk.
Okay, great. So next, I have a general question that is maybe a bit complicated to respond because it is to individual athletes. But at the end of a risk profile assessment, so when you have done your assessment, how would you classify the athlete and what is the next step? So what do we implement?
So what you're going to do is put your profile together. Hopefully you have 3 time points on the profile so that you've got some validation that it's repeatable, reproducible, and over time, say when returning from ACL injury, that there's been improvements and that they're, say, passing minimal criteria for each that you've developed or that you pull out of the literature. And then the next step is to design around your rehab, that as you target your rehab to any deficits that you see, but then also you lead them with a training program that's going to be very targeted to their risk profile, that they can continue to utilize, the handoff to their medical team or their strength coach or athletic trainer that's going to take them through a season and hopefully do that again. So safe return to sport is just that it. So what you're looking for is 3 things: that they return to their sport at the same level that they were before, that their performance is as good or better than it was before, and that they're safe or safer than they were before. And I think you have to meet all of those criteria. I think a lot of people say, well, we just want to get this athlete back to sport. Well, that's not good enough. Yeah. You have to get the athlete back to sport at a high performance level, again, preferably, after going through this grueling series of physical therapy and rehabilitation, surgery, that they're going to be better than they were before in time, but also that they're as safe or preferably safer than they were before, which is a challenge. I think you have to keep in mind that in a risk profile, any risk profile, prior injury is almost always the best predictor of future injury. So and that gives the therapist an advantage in some sense, because you have a high risk individual, and then you're developing a risk profile of a high risk individual. So that there are measurements that you can take that put that athlete at high risk, and hopefully they're neuromuscular, biomechanical, modifiable in nature, so that you can improve those scores and decrease their relative risk.
Okay, yes. I see the point. So last, and I will open with this, we focused a lot on the ACL because this is the subject of the web series. But is this type of profile, of risk profile methodology, could be applied to all the other injuries and sports also?
Yes, no doubt about it. And I think using that 5-factor maximum concept is solid across sports, across athletes, across injuries. because again, you don't want to get yourself into, I was working with the largest group of physical therapists in New York City, New York State, and they brought me in as a consultant because they were taking something like 17 different measurements. And when we looked at that data and called it out, what you see is there's only going to be 4 or 5 variables that actually really contribute well to that profile. Otherwise, when you get down to something that's contributing, say, less than 5 or 10% of the variation to your model, you can substitute out other factors that actually add to the model better than something that's really limiting. So I think it's important that, yes, in any sport, for any injury, that we collect data. I think that the aspect of getting the data together, taking the measurements, even that is helpful to the athlete, especially if you do it in a longitudinal sense, because then you can show improvement over time and give them some idea of what their risk of return might be, and give them target goals with their intervention to give them self-efficacy to say, look, I'm doing this targeted intervention to actually decrease my risk, which is going to help their psychological profile.
Okay, perfect. Great answer.
Great. This was very interesting. All the comments that you bring to us. So thank you so much, Dr. Hewett.
Yes, you're more than welcome. And again, I implore you to read that 5 factors maximum paper in Clinical Journal of Sports Medicine in 2019. That JOSPT paper on risk stratification rather than prediction in 2017. And there's a lot of good information out there in the literature. Read and know your literature. That's absolutely key. And there's a lot of good literature out there about risk stratification and profiling.
Okay, yeah, no problem. We are going to provide to everybody that is listening this the journal and the paper, and also providing slides about this stratification. So no problem.
That's great. Perfect. Thank you very much, Nathan. Thank you, Antoine. It's been a true pleasure.
Thank you very much.
Same for us.